So I'm really pleased today to welcome you to a session on the primary care strategy that the Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board are working on at the moment. This is your chance to hear from, we're really pleased to have Dan Leveson, who is Oxfordshire Place Director today, and Anna Marcus, the Head of Primary Care Integration. So they're going to talk about the strategy to start with, and they've got some slides to share. And then we're going to open up the floor to your questions. And as I said, questions can be in the chat, or I will keep an eye on hands raised. So really warm welcome to Anna and Dan, and we will hand over to you to talk about the primary care strategy.
Thanks, Veronica, and nice to see some faces and some names on the board there. So we've got a very brief presentation between Anna and I, and then plenty of time for any questions. Like Veronica said, my name's Dan Leveson. I'm Place Director for Oxfordshire, which essentially means I'm responsible for convening and bringing together the leadership from the entire Oxfordshire health and care system to try and find ways of joining up care, getting better outcomes for certain populations who'll benefit from more joined up care, reducing health inequalities and finding new, more sustainable ways of delivering the care that we deliver. Next slide, please, Julia. So very briefly, back in last year, July, we came into, there was a formal Health and Care Act that constituted 42, I think it is, integrated care boards. We are part of the Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board. So it's the forming of, previously it was 3 clinical commissioning groups. So many of you may be familiar with the clinical commissioning groups of old. We're now a single integrated care board. Our responsibility is to plan, buy and oversee health services for almost 2 million people across that patch. And that includes as a system. So, and I think the next slide, if we can move on, Julia, the next slide gives a little bit more detail, but as a system that includes local authorities, voluntary sector and other parts of the public sector. So the 3 main parts of the system that you might be interested in, you may not be that interested in it, is the Integrated Care Board. So that's what who employs me. And we have the statutory NHS responsibility for planning and contracting health services. So we hold the NHS budget. We also have a formal statutory board that is the Integrated Care Partnership, and that's the one that represents NHS and local authorities with social care responsibilities across the whole patch. And again, that's quite interesting because it's the only real formal place that you'll see NHS and local authorities at that scale working together. So really quite important. And then the integrated care system is the whole system that we work in. I think the bit that's missing here that I will mention is in the guidance when we were set up as integrated care systems, there's two key and what's called engine rooms for integration. So that's place-based partnerships, which is what I lead. And that's the bringing together of the leadership from across the entire system to find the ways of joining up care, and provider collaboratives. And those are partnerships of different providers of health and social care that are encouraged to come together and work together to deliver care. Whereas in the past, we've, as many of you may know, we've had a system where we've been competing for lots of small contracts. Now we're being encouraged to find ways of working together and have fewer competitive contracted services. Next slide, please, Julia. This is a pictorial of what we have in the whole of BOB, as Buckinghamshire, Oxfordshire and Berkshire West is affectionately known. So like I said, nearly 2 million people, 3 acute and integrated health trusts, 250 care homes, 50 primary care networks, so 157 GPs, 2 mental health trusts, 182 dental practices, nearly 70,000 staff work in health and care, loads of community providers, 800 schools. We have the wonderful health watches in the 5 local authorities that are the 5 unit or the 5 upper tier local authorities. 5 universities, again, really important part of our infrastructure and opportunities. Loads of really vibrant voluntary and community sector organisations, many of whom may be represented on this call today. We have the 5 district councils that I'll talk about a little bit in the next slide. We have an ambulance trust, 260 pharmacies. So yeah, it's, as you can imagine, a fairly complex system that we work in. Next slide, please, Julia. And then obviously where hopefully why most people are tuning into this one and where my main time and interest is in the Oxfordshire part of our system. So that's Oxfordshire, as everyone is probably aware. We are one of the most rural counties in the south of England, in the southeast of England. Having said that, we also have quite significant health inequalities. So we know we have 10 of the most deprived wards in the country. So 6 in Oxford City, 3 in Banbury and 1 around Abingdon, Caldecott. And obviously what that brings with it is quite a difference in health inequalities and healthy lives lived. And it's an area that we are paying increasingly more attention to, about how we can reduce the health inequalities and improve the outcomes, particularly for people living in deprived areas or for other excluded groups like people living with learning disabilities, homeless people, people with severe mental illnesses, and people who are not white, so Black, Asian or minority ethnic groups. Oxfordshire itself, so the system that we live in, and I work in, we have the Oxford Health as an integrated community and mental health trust. So they are the people that provide all of the community services and all of our mental health services, alongside quite often partnerships with voluntary sector and things like that. We obviously have Oxfordshire County Council, the upper tier authority, and 5 city and district councils, and they're really important for us because they're the people that are responsible for planning. They're also the people that are responsible for the leisure facilities and other stuff like libraries and stuff like that. So really important network and contact for us. We have 20 primary care networks, 67 GP practices. I'm sure we'll talk more about GPs later. And then 1 very large acute hospital trust, so the Oxford University Hospital Trust, that has multiple different hospitals spread out across the county and also delivers a lot of care out in people's homes and in communities. So that's a little whistle stop of our system. I'll hand over to Anna now to give a bit more detail about the primary care strategy.
Hello, my name is Anna Marcus, and yes, I'm part of the primary care team at the Bob ICB, so the Buckinghamshire, Oxfordshire, and Berkshire West Bob, affectionately as it's known. What we're here to talk about today is the primary care strategy. And as you'll see, while many of the organizations within Bob have been working closely together for some time, it is fairly new that Bob has come together as this integrated care board. And back in the spring, we had developed a joint forward strategy for how to work together. And it was recognized at that point that we needed to have a bit more dedicated time to really focus in on the primary care strategy for Bob. So primary care here, we're talking about general practice services. So when you're seeing your GP at the surgery, but we're also talking about community pharmacy, dentistry, as well as optometry or eye health services. So at a national level, there was a plan that was put together about a year ago called the Fuller Stocktake that really set out a vision for what primary care could look like in the future, especially given the pressures that we're experiencing across the country. And it really emphasized 3 key areas, which is what we're really going to be focusing on within Bob. So access to care, continuity, and prevention. And so we're putting together the Bob local vision of what this is going to look like and how we can really bring this to life in Bob, which is what we're here to talk to you about today. So if we go to the next slide, So the first part of the strategy is really getting a sense first of what the current state is in Bob. And so this is just highlighting some of the key stats from the report and getting a sense of where we're at. So I think, as you all know, demand is increasing for primary care. More people are trying to go see their GP, dentist, go to pharmacy services. Bob in particular is experiencing a growing population, which means that demand is ever increasing as the needs are also becoming more complex, particularly from the pandemic and an aging population. And unfortunately, we're in a place too where capacity is not keeping pace with demand. So I think you'll have seen plenty of news stories about workforce shortages across the patch. In particular, having a difficult time with recruiting more GPs. And so what we're experiencing is that GP surgeries, for instance, are having to manage more patients than in the past, just part of where we're getting into this difficulty with accessing the practices. Estates we know are not in a good state across the board. And there are a lot of challenges to being able to develop primary care estates. Your practice staff at surgeries would like to spend more time on prevention and chronic care, as we've seen in some surveys, and that's just challenging with being able to also meet the demand for same-day needs. And then again, we're experiencing different health outcomes depending on the area of where people live, and so people in our more deprived areas in the patch have poorer health earlier than in other areas. So all of this, I think, goes to show it makes sense that we're seeing that patient dissatisfaction is increasing over the years. But this is a problem that I think Bob is really interested in seeing how we can make things better for patients. So if we go to the next slide. So this is where we get into the strategy development. And so what Bob has started to do as an organization is to first off get an idea of what the current state is of primary care in the patch. We also want to be able to identify where things are going really well so that we can see if something's happening really great in one place, we'd like to be able to spread that to other places as well. And taking all of these learnings and understanding of where we are, really start to design what that new approach is to primary and community care delivery across the system. So what we've started to do is we've brought together stakeholders we kicked off with a strategy day back in October. So this brought together stakeholders from kind of all parts of primary care. So general practice, dentistry, pharmacy, optometry. It also included stakeholders from our voluntary services, Healthwatch, patient participation groups, public health. And we've continued to engage with all of these groups too on an ongoing basis to inform the strategy. And so that's part of why we're here today, to speak with you, to talk about the strategy more. So if we go to the next slide, you'll be able to access more documents on the website if you want more detail than this, but this is really just the high level aims and draft vision of this strategy. So coalescing around these kind of three focus areas. Access is making sure that people get to the right support the first time to meet their needs. And so this is really understanding too kind of what the needs are that are coming in and getting patients to the right place. So sometimes the right place might not actually be the GP surgery. Sometimes it might actually be pharmacy services. So it's doing more to have that effective triage in place to get people to the right place at the right time, so that people are able to address urgent needs as they're coming up. It also means a focus on continuity. So particularly for people who are experiencing medically complex or socially complex conditions, having more wraparound and proactive services for patients to make sure that they're getting more personalized care and that it's better meeting the needs of people with those more complex and long-term conditions. The last bit of this too is prevention. So as an integrated care board, we have the ability to better use data to identify patients that maybe we want to target for different interventions, increase our focus on early years preventions, and expand community outreach. So particularly if there are patients who are falling through the cracks for any reason, being able to get more out into the community and to try and have more of these preventative interventions to help keep people healthy longer. So this is our draft vision for discussion, making sure that everyone in Buckinghamshire, Oxfordshire, and Berkshire West has equal access to coordinated and integrated primary care that meets the needs of the population and enables people to live happier and healthier lives, and move care closer to where people live, so more out into the community rather than people necessarily having to go to the hospital, but being able to stay healthy and at home where possible. So I think that's it for my slides. I think we'll probably turn it back over to Healthwatch.
If you want to stop sharing the slides. Thank you. So thank you for that overview. And I think the last slide and in the chat will show you how you can also feedback via the Integrated Care Board. They've got a survey up, which gives you a chance to leave your comments. So I'd like to open the floor to questions and from the public. So has anyone got any questions? And the way to do this is to put your hand up in the chat. So yes, I can see a question from Tony Eade. Tony, would you like to ask? And just to remind you, if you don't want to be filmed, just keep your video off.
Yeah, thank you very much. I'll try and keep it fairly brief, because it's about a specific area and about how one can contribute one's views, not individually but as a group. But basically, I'm a resident of Littlemore, which is part of southeast Oxford, and I'm also involved in getting together a neighbourhood plan, and part of that is considerable dissatisfaction, which I think is justified, about the primary care facilities and accessibility to those in an area of fairly considerable deprivation, and also one which is going to, the population is going to grow almost certainly in the next 5 or 10 years. I suppose my question very simply is, how does one go about engaging with yourselves in order to put a case for improving primary care, and discussing the sort of basis of that? And I'm sort of speaking on behalf of a group. I mean, I haven't checked it with them, but there is a group of people who I could do that. So that's basically my question. Thanks very much.
If I jump in, and I don't know if anyone has anything to add, but Tony, thanks very much for the question. We are aware of it, and actually the best way, so I'm in very regular contact now with Sandy Douglas, the councillor for Littlemore, and we've had lots of conversations with Sandy, and obviously, as you know, we've got general practice in Blackbird Leys, and we also have they provide an additional acute care hub at Blackbird Leys, and conversations with Donington and Temple Cowley. So I would suggest the best way, Tony, is to keep in contact regularly with Sandy, and so that we're having that, and when the time is right, we can bring people together. So we are aware of it, Tony. So thank you.
Yeah, if I can just respond very quickly, yes, I am in contact with Sandy, and I know he's been in contact with you. But he's obviously coming from being a city councillor and also a medical doctor himself. But there are other people who I think it would be helpful to extend that discussion to. So thanks very much for your answer, and I hope that can be taken forward.
Thank you, Tony.
Fruitfully.
If I could also offer up too, I think that's going to be particularly helpful for Oxfordshire. I think as an integrated care board too, I think we are establishing more of a patient advisory group too. So I'm going to put an email in the chat as well. If anyone is interested in joining that group, you can email that as well.
Okay, thank you. We've also got a question from Sarah Wild. Sarah, would you like to ask your question?
Okay, thank you very much. When Anna was talking, it does seem a very top-down approach, saying, you know, we want views of people, this, that, and the other, and you're talking to well, basically stakeholders, but the stakeholders you're talking to are all providers. They are not the people who are receiving the care. And there's as Tony said in Littlemore, people are not being listened to. And I would like to state here that patients are not being listened to, only the care providers. Sorry, so it does seem to me that you're actually setting up a system that suits you, not patients.
Anna, do you want to respond at all? And then I can add some stuff.
Sure. No, I think that's a totally fair critique. And I think this is the beginning stages of being able to speak directly with patients, because we think that is important. And I know that we've had a difficult time, I think, really establishing how to work more closely with patient groups in the past as an integrated care board. And we're really trying to take forward kind of new ways of working and better reaching and more regularly engaging with patient groups so that we can keep in touch. I think that there are going to be a couple different levels too of working with patients directly. There's going to be kind of at the integrated care board level where we're doing things like designing the strategies, but I think that there's also too at a more local level, as we're starting to design new types of services and new ways of working. I think that's also where we need to get into more of this co-design of services together at a more local level. So I think there are going to be a few different ways that we need to more regularly engage with patients. And this is only one kind of small start to some of that. Dan, I don't know if there's anything else you'd want to add, but.
Well, no, Veronica might be able to help, but we do, obviously, we engage the patient participation groups. Is, I think, from a route as far as primary care goes, and particularly with regard to general practice, engagement with patient participation groups, the PPGs, is a good route in, and we do have regular feedback and contact with them.
Yeah, so I'll just add, hello, Sarah, nice to see you. Healthwatch Oxfordshire has been in a role of supporting sort of networking between patient participation groups. And I think I'm very aware that whole landscape's changed very much since the pandemic, and also with the emergence of the primary care networks. And what I want to do coming into the new year is reach out much more proactively to patient groups so that we understand what their needs are in terms of support, and we can help to link you with that communication, better communication with the integrated care board. I think there's a principle Sarah's sort of raising more widely about patient engagement with routes into communication with the integrated care board. And I think, as Anna has acknowledged, you know, I think there is still a way to go. So would really welcome more reaching out to engage patients in this way. I'm just going to come to another question that's in the chat. This is from Jan Cottle. I'm interested in learning about what is new, how a service is going to improve or change if needed. We've heard the overview vision, but is there the detail on the web? So perhaps you can comment about that. Thank you.
Yeah, and I think, so right now, because we're in the earlier stages of developing the strategy, we don't have the detail yet of new services. I don't know if someone in Oxfordshire would want to come in to maybe speak a little bit about what some of those examples might be, but I think that would be the intent, is to be able to highlight across the 3 different areas within Bob what are some of these examples of new ways of working together. That'll come together as the strategy continues to develop, but it's still in these early stages. Dan, yeah.
Yeah, so Anna, it's probably worth mentioning one of the key features of our GP for GPs, particularly in primary care, is going to be the introduction of things called integrated neighbourhood teams. So what we're trying to do is, at a neighbourhood level that probably covers about 30 to 50,000 population, bring the right people together. So you bring GPs with pharmacists, with mental health practitioners, with social workers and things like that, and really support people, particularly frail people. So this isn't necessarily old frail people. This is either old frail people who may have a fall or be at a risk of falling, or younger people with multiple illnesses that require a little bit more continuity than someone like me, who is, let's say, reasonably young and reasonably fit and healthy right now. So every now and again, I will need to see someone in a primary care setting to get me back to work or get me well again. And so what we aim to do is make sure that we have the right services for someone like me, who can probably access this digitally or get a phone consultation and go and pick up a prescription, and then make sure we have these integrated teams that really start to work much more on continuity to support people, so they spend more time at home or able to work and things like that. So that's really one of the key features of our strategy, and that will include the integration with things like community pharmacy. So we know things like pharmacists have a really important role to play, particularly in helping people at home or in their communities.
Thank you. I'd like to bring in David Ruan, who's got his hand raised to ask a question.
Yeah, my question was about how you reach out to people who don't think of themselves as patients. That's the point you just made, Dan. I think that patient participation groups are, by their very nature, made up of people who use the service regularly and think of themselves in that way. It's how do you reach out to get the views of people who access the system occasionally and really don't know how to do it, because there's obviously a knack to getting an appointment with a GP, but unless you're well practiced within the system, you don't know what that is. So will you be reaching out to workforces, for example, to major employers to talk to their staff about how they do? Because I think these are people who are not often thought of within the healthcare system because they don't use it very often, but when they do need to use it, it can be urgent and important.
Yeah, it's a really good question, David. And one of the things that I am conscious about, actually, when we talk about PPGs, and I did see the comment in the chat about PPGs, is quite often the people that we don't have regular contact with are also the people that don't actually access their healthcare kind of facilities when they need it, and they're definitely not the people that are in part of the PPGs. And I do think this is one of the benefits in Oxfordshire of the close working relationships that I have both with, or we have both with, public health and the county council. So the public health have done such a great amount of work, and again, I'm going to name check Veronica and Healthwatch around this community research network. So we're really building up quite a lot of really good stuff in the communities that understand what communities need, what assets there are in the communities, who people are, and things like that. So really using those contacts alongside the city and district councils, who again are really embedded and understand their communities and understands what's in the communities. And I suppose, to give an example of the work that we're doing, we're working very closely with voluntary and community sector groups, building on the work that was done both with the community research networks that I mentioned before, as well as the community profiles. I don't know if anyone ever accesses the Joint Strategic Needs Assessment on the Oxfordshire County Council, but again, a great resource to helping us understand what people are saying and what people want and how to connect, as well as these community profiles that were particularly focused in the most deprived areas. And this has given us such an insight and such a connection with so many of the different parts of the communities that we've just got to keep working on it. But David, there is a point about, and I think what we know is involvement and engagement requires lots of effort, energy, and hard work, and we need to keep doing it, and we need to find ways of doing it. And it's not a one-off, we're going to do a consultation, we're going to come to a village hall. It needs to just be part of how we do things, and we're learning as we go. But I do think actually we're learning a lot from our colleagues particularly in local authorities, as well as some of the voluntary sector communities.
Thank you. I can see there's 4 hands up, but first I'm going to come to a question in the chat from Ben Pierce. It says the needs of those with severe mental illness are not being met across the county now. As an ICB, you're not meeting the national target of 60% of this group receiving annual health review. Interventions, including dentistry, are proving challenging to the general population, let alone to those with severe mental illness. What strategic objectives are being developed to meet this new vision to ensure parity for this vulnerable group? Is the voice of them being heard in this co-production process?
Again, a really great question. I go back to what I was saying before. Ben's actually absolutely right. So what we know about people with severe mental illnesses is they often have lower life expectancy. So I think the life expectancy for someone with severe mental illness is something like 75, and God knows if you have severe mental illnesses and combined with living in deprived areas, it's probably worse. So we are conscious of it. We do have a separate stream of work to the primary care strategy, working with Oxford Health and the voluntary sector. So the mental health partnership made up of Restore, Response, Mind, Elmore, and others, to come up with ways of improving that. And actually, we've got so the place-based partnership that I oversee, one of our key priorities is mental health. So what for the next 12 months to 2 years is really focusing on improving the outcomes for people, adults and older adults with mental health, while we also run the special educational needs and disability improvement alongside it. So then there is a lot of work going on. I think connecting with Oxford Health and the mental health partnership is really key with that one.
Thank you. I'd like to come to Don O'Neill, who's got a question to ask.
Thanks, Veronica. Yeah, people always talk about how it's very hard to find an NHS dentist. So are there any plans to increase the number of NHS dentists across the county?
I'll actually ask my colleague Julie, maybe on the line. Julie, if you're there, yeah.
Yeah, hi there. I don't know if, oh yes, look, I'm there in the top right screen. But yes, thank you for that question. I'm part of the Integrated Care Board with a responsibility for primary care in Oxfordshire, but also more recently for pharmacy, optometry and dentistry across the BOB footprint. And really recognise the issues with access to dental services, although we do have slightly more of our population accessing NHS dental services than the national average. We are doing more to try and get some more access. We do have a scheme that provides additional appointments for or puts on specific appointments for those in our most vulnerable groups, and we've discussed a few of those today. We are also looking at commissioning more. We're in the process of putting in place some more appointments from April across the patch and going out to that. We're aware that there are issues with the national dental contract, and that we have had a number of dentists say that they no longer want to provide NHS dental services. So we are trying to work to make sure that we can improve access, and some of the learning that we've done in the last year when we became responsible for that commissioning will help us feed into the strategy and move that forward. But I think it's a really good point that's really recognised, and something that we're working hard to do. I don't know whether we would necessarily get more dental practices, but what we want to do is just increase that capacity so that more people can reach out and get NHS dentistry.
Thank you very much. I'd like to ask Robert to put his question.
Monica, so I think it's a lot of great stuff, and I've had a look at the sort of summary paper, but I guess I'm getting a bit unclear about what the strategy is trying to deliver. It might be helpful, because you can have a strategy to deliver solutions for things that you know exist, or something to sort of design solutions. And we know there's some really existing problems like access, premises, workforce, and the summary paper seems to sort of be trying to do it all. I guess it's just sort of what the strategy do. Does it bring money in? Does it mean that resources are prioritised for it? You know, what time period it is? This is some. It'd be good to know sort of what does the strategy do, as well as sort of, you know, what's in it.
Yeah, so I can speak to that. I mean, I think a big part of it is, first of all, just acknowledging that primary care can't do this alone. We need to really engage with all of our system partners and have a collective and shared understanding of what the challenges are to start, so that we get collective solutions on how to move forward. But so I think too, part of this is going to be that we want to be able to identify clearly what the problems are, and really have some clear focus areas too. So I think not trying to fix every single problem that there is, but identify the top priority areas. So that's another piece that the strategy is also trying to achieve. But, you know, I think you're sort of alluding to, I think that the some of these issues that we have identified are going to be really difficult to solve for. And so I think we really want to be able to identify what we can do in the shorter term. So around things like access to the clinic and expanding access for right now with the capacity and resources that we have today, because there isn't going to be a ton of new money. So it is thinking about working a bit differently with the resources that we have today. We're getting some kind of smaller pots of money, but it's not increasing hugely. And setting out some both short-term solutions that we want to try and meet, while also having a longer-term vision. So something like premises, for example, and primary care estates, that's a very long-term problem. It's going to have some long-term solutions needed, but there are some things that we could also do in the shorter term. And that's where we're trying to identify best practices to see what we could improve today and make better. So while we might not be able to set up as many new GP surgeries as we would like, we can do things like maybe co-location of services at some existing estates, looking at all of our different partners and what estates we have today to see if we can put multidisciplinary teams into one space, as an example, to try and address some of these issues of not enough estates in primary care. So I think it's gonna be a bit of a mix, but it's identifying very clearly what the system problems are, really have a tighter focus on what are our priorities going to be as a system, and then having both short and long-term solutions that we're going to try and achieve. And where somebody's already solved something, I think that's where we're trying to identify the best practices. We don't reinvent the wheel, but can try things that we've seen work in other places.
Thanks.
Does that help?
Yeah, and I've said that's a really clear explanation. So I just wonder, it would be helpful to sort of lead with that when you're presenting, because it just might help manage expectations.
Yeah.
If the public, you know, it's to sort of say that there's not going to be a ton of new resources, but that sort of narrative is actually quite clear. I think it might help manage expectations.
Sure.
Thank you. And I think the comment from Robin Carr in the chat sort of emphasises some of those constraints that particularly GPs are working at. That's worth a read. So I'd like to bring in Geraldine, who's got a question, please.
Thank you. It feels like a lot of this is plastering over problems and not actually dealing with the problems themselves. There are too few GPs. What's being done to recruit more and to encourage them to stay in the area? What is being done about buildings? I should say I'm from a PPG, and we have had a lot of problems in our practice, which has merged with others, because one of the buildings is owned by NHS Property Services, and they don't do their job properly. What is Bob doing about them? I mean, can't they be dismissed and certainly not be allowed to call themselves NHS property services, because it doesn't seem to me that they're working for the NHS at all in the sense of making things better for patients. They may be making a lot of money out of it, but that's all. And community pharmacies. There's a problem with pharmacies because they're not paid enough to do the work that they're asked to do in processing prescriptions. And these are things that you can rearrange all the chairs and perhaps make things a bit better. And I'm sure there are more efficient ways of helping patients. But really, I think that you need Bob, ICB, to be making lots of noise upwards about what the problems are. You know, that's the elephant in the room. We need more resources. And okay, you can say, well, we don't have any, and so we've got to work with what we've got. But you also need to be rioting about the fact that more is needed, I think. And until you can do that, we're not going to achieve a lot. So I'd like to know what Bob is doing upwards rather than downwards.
So I'll leave it to my colleagues in primary care to answer the specific questions about the estate and the workforce and things like that. And Geraldine, I just wanted to say, I think what you're saying is we need to do both. I would contest that what we're describing is a rearranging of the deck chairs, developing integrated neighbourhood teams, developing 24-hour primary care services that are integrated is far beyond it. And I think what we are looking at is developing a system of primary care, an integrated system of primary care that is fit for the next 50 years, and not necessarily just redesigning the system that we currently have. I think so, but I think what you're saying is doing both. But I'll leave it to Julie or Anna on the specifics around NHS property and estate and workforce, I suppose.
Yeah, if I could come in, Anna, if that's okay. So yes, so totally take on board all your points, and I've got a good guess of which practice, which building you're talking about, Geraldine, and also recognise the frustrations that you as patients face by some of the goings on, and also patients across the rest of Oxfordshire. We do make noise. We do put pressure upwards and feed concerns in, as we know do our GP colleagues, our local pharmaceutical committee, our local dental committee, and do feed suggestions up there. Any change is very, very slow. We are supposed to be having a new GP contract from the 1st of April. Haven't seen anything yet. Expecting just to have a rollover from last year into next year, whilst more debates and negotiations go on. So I think what we are very keen to do as Bob is, what are the things that we can influence? What are the things that we can make a difference on? And I think some of the things that we've heard from the public, from patients, is about that access, and having which is what we're trying to build into our strategy, and also having continuity of care. I think I've talked on this forum previously on a number of occasions, one of which I think was on estates, but also that continuity of care that we know that's important. You did mention about workforce and what are we doing to keep GPs here. I think some of that is in our gift. We've set up quite a successful new to practice GP fellowship scheme that has 30 new GPs that we sort of provide a bit more support and mentoring to as they enter the world of general practice. And okay, it's a small number, but I think those are the things that we need to do. We also need to be allowing our GP colleagues to do other things alongside general practice, that sort of portfolio career, and some of that is helping we're developing through this sort of fellowship, so that they could do, I don't know, 6 sessions in GP practices, so 3 days in a GP practice and a day at the university. We've got so much to offer across Oxfordshire that we just really need to be capitalising on it. But yes, I sometimes wish I had a back pocket full of GPs, because I think that would solve a lot of the primary care issues.
Thank you.
Thank you, Julie. Jeanette Searle, we'll come to you next.
Thanks, Veronica. I'm wheeling back a bit on the engagement point, and specifically engaging with people with experience of mental illness. And not to, I hope, repeat what's been already said, but a couple of things that I wanted to draw out from that. So obviously there's a lot to do and things have to be carved up in particular ways, but there is an important overlap between that particular community and primary care work in terms of health inequalities. So if I can draw it out by a particular example, as many people will know, people with a mental illness are more likely to die of cancer. They're not more likely to get cancer if you control for all other variables, but they are less likely to attend screening. They're less likely to attend for health checks. That results in later diagnosis, as well as other barriers to accessing primary care, and then potentially also less take up of treatments. That's all about access to primary care from a particular section of the community, which is then perpetuating a health inequality. So we have to be careful not to look at mental health in a separate box. This is important in terms of the primary care work. And I just wanted to highlight, in terms of bringing that voice into the work on primary care, the Oxfordshire Mental Health Partnership, which Dan mentioned previously, has got a specific involvement subgroup, which is bringing together the lived experience work which is happening across all of the organisations that are part of that partnership. And that group brings people together to influence the partnership and the members for the good, but also to advocate for better health and better outcomes for people with mental illness generally. So we're always looking out for other opportunities, places we can connect people in, support them to take part in things. It's on a 6-month rolling basis that we chair it. So Oxfordshire, my organisation, is chairing that group at the moment. In 6 months' time, we'll be one of the other partners. But if you would like to be connected with that group, I'll put the contact details in the chat, and I'm sure they'd love to be talking to you about this.
I think there's nothing to add on that. That was,
Yeah,
Jeanette, thanks very much. And I think what we're really aware of, particularly, and when we talk to colleagues in GPs and primary care in general, is a huge amount of the work in primary care and in communities is mental health. And I think from an integrated care point of view, I'm really conscious as well that good integrated care is going to be built around primary care services and mental health services. So, but Jeanette, I think I couldn't have said it anywhere near as well as you. So thank you.
And I think just to add on from that, Dan, you know, this is the very start of the engagement. This is the real start of the discussion of the strategy and what is important. I think after Christmas we hope to be able to take a few more sort of concrete proposals out to various groups, including those seldom heard groups that we described. So any sort of links in that we have, and Veronica, I think we'd very much like to come back and do some more discussions in the new year about what we really mean by improving access, some of the suggestions that we have, and how they might land with the public.
Thank you. Yes, absolutely. That would be good. There's a question in the chat from Andrea, which sort of leads well on from that. It's a sort of statement and question. The aims and draft vision sound really inspiring. Do you have any more information on how you plan to develop access in a patient-friendly strategy? Meetings such as this are really helpful. PPG chairs can feed back to patients and practices. But communication, particularly for patients who don't access IT, laptops and so on, is a key issue. So it sort of speaks to what you've just mentioned. Perhaps you could develop, just while we're finishing up now, where the strategy goes and what the process is next.
Yeah, so I think maybe just on the process for the strategy, I think we're taking in this time to get a lot of input from the public so that we can refine the strategy, make changes, make updates. And I think if there are things that we have not done enough of yet, we can kind of amplify them. But I think things such as, how do we better work with our PPG chairs to develop ways to communicate with the broader community that they're reaching, it is one area that I think we have more work to do there and would like to do more work with our PPG chairs to develop and make sure that we're not excluding anyone who is not on a laptop or smartphone more regularly. That's definitely an area that I think is something we're trying to be very mindful of, how we develop both the capabilities of the practice to be able to more efficiently manage patients who are coming to the door, and doing some things like getting an appointment online is one way to get an appointment with GP surgeries, for instance, but we're trying to shore up the infrastructure so that if patients are calling into the practice as well, that's easier. The queue is better managed. But I think that there's going to be a lot more work to do the more proactive engagement with the community too, for anybody who is feeling less certain about how to navigate the NHS and getting into primary care. Dan, Julie, I don't know if there's anything else you want to add.
And then final question, I think, before we wrap up, is from Tony.
Yeah, thanks very much. It's just a very brief one, really. Can you give a broad outline of sort of timing of when you think there might be a draft strategy? I'm not sure about the timing for the engagement because that's gone in the chat, but are we talking about having a document in a year's time, or 18 months, or just sort of a vague indication or a precise indication?
Yeah, we are planning to take a draft of the strategy to the Bob board by, I believe it's either March or April. So definitely not a year-long strategy development. It's going to be definitely within the next 6 months.
Yeah, I think yeah, planning. So we're currently planning this at the moment in our timelines. I think there's hope that we will have a draft strategy that we can share for engagement, for discussion with groups like this in the new year, to potentially then have some engagement time with various groups, and potentially sign something off in our springboard, probably, as Anna said, April, May-ish time. I think we recognize the importance that we need to be there's no good publishing something that we haven't engaged and making sure it's ticking the right boxes on. So we want to do a good piece of work in the new year to try and get that sort of feedback and engagement as to whether we are on the right line, but also recognize, we don't just want to take out a blank piece of paper, because take out a blank piece of paper to lots of different groups, you sort of get, so we've got a bit of structure and some suggestions, but yes, so as Anna says, we hope to have something published and with a implementation plan definitely by the summer.
Okay, that's really great. Thank you so much to Dan, Anna, and Julie, and everyone for talking about this really important strategy. And I think, as you say, this is a first step, and it's great to see that you're starting to reach out and hear these voices, and we'd be really keen to continue that supporting that dialogue with Healthwatch Oxfordshire in between, if that's helpful. And thank you everyone for really good contributions and discussion. Please do continue to give your feedback into the integrated care board process, which is in the links in the website, and we'll continue to show you how to do that, as well as the ICB. I was just looking to see if there's any more questions, but I think we are done. Someone's asked, can we add the slides to the website? So yes, the slides and the recording of this session will be available for other people to look at in their own time, and we will put them on our Healthwatch Oxfordshire website. So that's both the recording and the slides from the session. So with that, we can see someone's clapping, which is nice. Thank you. So thank you ever so much to everyone for that really good discussion. It was great to hear from you all, and thank you for coming on a Friday morning.
Thanks, Veronica, for hosting, and thanks everyone for coming. That was really great. So thank you. Look forward to future events.
Great. And we'll stop recording there.
Cheers.
Thanks.